going to talk about Noughties to now, our journey as occupational therapists within the mental health setting. So we're really, really pleased they're here. Thank you for coming, and we're looking forward to hearing what you've got to say.
So I'm Hayley, I'm a clinical specialist occupational therapist working for the Early Intervention Service for Psychosis. And I've been there for around 16 years. What we're looking for today is just to share our journey through KMPT, which should be a really nice follow on from the presentation beforehand. So I'll hand you over to the slides.
So my name's Dunton, I'm a systemic therapist, and I'm also a occupational therapy. And Hayley's kind of touched upon, we're trying to come up with something different today. So we're going to be looking at kind of our story working in mental health as occupational therapists. And also we thought we'd kind of incorporate something slightly different and look at some historical events as well. Some people might not recognise, remember these, or probably those who don't. So we both graduated in 1999. At the time, President Clinton, there was no impeachment at the time. Launch of the euro occurred, minimum wage of £3.60. We had a Labour government, so that's anything more. Nationalist radio contact with Mark Landa, and also we were fast approaching the millennium. Everybody was really, really, really worried about what was going to happen kind of just before midnight with regards to the millennium. With regards to reports and legislation and policy, the Sleep Knowledge report has just been published and it's outlining the systemic racism found in the police force. And there was also the National Service Frameworks. And when I hear them speak about national frameworks, I just feel so old. And I think that's kind of 20 years ago. But it's really important for mental health. It was looking at combating discrimination against individuals and groups of mental health difficulties, making it easier, which we're still trying to do, for people to access mental health services and create a range of mental health services to prevent or anticipate crisis and early intervene.
So I started my OT journey in 1999, and I think like many of us, you come out of your 3-year training thinking, where do I go next? And I took on a 2-year rotation, which gave me an opportunity to spend 6 months in 4 different areas to really get a feel of where you want to go next. I did 6 months of learning disability, which I loved, community and inpatients, a real opportunity to be able to use my skills. Moved into elderly inpatient mental health, which again was an eye-opener for a young 21-year-old, but again, a great experience. 6 months in acute inpatient mental health, and this is where my passion started. Absolutely loved it, and knew at this point that mental health was where I was going to be, and what was right for me, both as my personality, but also as an OT and where I wanted to develop. I did a really short stint in physical inpatient elderly, but realised it wasn't for me. I was really lucky to be able to develop further through mental health.
So my first position was in a acute psychiatric mental health hospital. For me, very quickly, I knew that my physical wasn't the way I was going down. I arrived for this interview for a cold, I finished my dissertation, and I was very much as a practice interview. I wanted to go somewhere else. I wanted to work with Slow at the time. And I can still remember the feeling when I arrived, I was like, oh my God, this is where I want to be. And I had to turn the interview around so quickly. And today, it's been my 22-year career of working. It's the best interview I've ever done. I often wonder kind of that's when, because I went to law, I'm not sure, the position. Very traditional role of OT, kind of running groups, functional assessments and home visits. And I'm always forever grateful. We had an absolutely wonderful head OT at the time. It just allowed us, we were relatively qualified, and allowed us to be really playful and creative. We had, I think, presentation earlier on, there's reference made to basket making. I can bore people senseless about the benefits and the purpose of basket making. I just think it can be such an important activity to kind of know clinicians speak about, let's speak about the benefits. I refuse to lie, I think it can be a really meaningful occupation. At the time when I was working in Q, it was very much kind of nurses with board managers. It was very much kind of set up like that. And I think it's been really evolving about the role of OT today. You know, deputy board managers, board managers, core profession of occupational therapy. And the other thing I would just say, I think kind of OT as well is kind of adapted to working with things with regards to kind of also working with big things and kind of out of hours, which I think is really important. So we move on to the next decade, so 2000 to 2010. This decade saw Golden Jubilee of the Queen. We saw some really awful atrocities. We saw the London bombings, we saw 9/11. People's lives changed forever, and families' lives changed forever. We saw things like Heathrow Terminal 5 being opened, and we saw ban smoking in all enclosed workplaces. Sorry, that's not keen, that's not how this back over. And again, there was more legislation, there was more policy occurring. The NHS plan, 10-year modernisation programme for investments, mental health, crisis teams, assertive outreach teams, again looking to improve the quality of care and reducing waiting times. Introduction of hospital rating system and the care quality commission arising.
So 2000 to 2010 for me started still in inpatient ward as a senior 2 OT in the time then, developing ward-based activities, supporting people who were in crisis and poorly to be able to develop and move out of the wards back into the community. And it was at this point that my journey took me into the community and into assertive outreach, where I spent 3 years as a care coordinator, but still very much using my skills as an occupational therapist within the role of care coordinator. And spent a lot of time actually in that time in assertive outreach thinking about what the role of a care coordinator meant for an occupational therapist and how our skills actually fit really nicely within that role. And actually we didn't necessarily need to adapt ourselves. We could be us as OTs, but employ as a care coordinator, particularly in assertive outreach, where we worked with people who had been in the service for a long time, were very despondent, didn't want to engage, didn't want to see you, didn't want you banging on their door window, try and climb through the back door, anything you can just to try to get to see them. And OT very much needs to do with that. So then following on from assertive outreach, I went to the completely other end of the spectrum. I went to early intervention, which is the journey for someone just coming into mental health. So I've gone from the end to the beginning, where I am today still, but in terms of care coordinator, exactly the same. It was still about remembering I'm an occupational therapist. This is what I do as a care coordinator, and keep focusing that within the role to support, at this point, young people who are experiencing depressive episode psychosis.
Thank you. So 2000 saw me move into a regional secure unit, working alongside individuals who have committed an index offence as a result of mental health crisis, often kind of moving in this aspects like that restricted by the Home Office. Within the regional secure unit, we had a mission, acute, long stay, and rehab units. And the length of stay for some of these young people, 20 years, and often institutionalised, lots of kind of really DDLs, often highly medicated, and risk and safety was a really, really high context. For me, there was something about kind of opening this client group, and I started to become a key worker, which was traditionally a nurse's role. And it really, really felt comfortable for me. I thought kind of just fitted every aspect of the values and beliefs of OT. I think kind of always struck by the love and passion, you know, working within the regional secure unit. And I think kind of there's such an important role there as well for OT, where we're losing aspects of ODLs, things like, you know, we do coping assessment, coping programs with people, and just getting a choice of timing, aspects that kind of just so nice being institutionalised within the environment. I moved on to the crisis team after this, and I'm still very familiar from memories of working in the crisis team, and working on some people who are in a crisis, and alternative justice commission. For me, it's very different. When I work here, it was 24 hours, it's 7 days a week. At the very much meant as a hobby, and I really wanted to hold on to my professional idea eventually. I remember I struggled to start with the classes too. This notion of going around and having a chat with somebody was so alien. I was so used to kind of using occupation to engage them, to have a conversation, to get that relationship going. So kind of had to be really creative about how we used occupation. And possibly did it in a slightly different way. Checking out people, they watch on television, that could be used to kind of assess how they were doing to help their mental health. They could find out if they're able to concentrate, if they've been able to sit down, if they've been able to kind of just hold something in there. And always bearing in mind what was really important for that person in the process of recovering from a crisis presentation. So I keep trying to. So 2010, there has been so much to now. We've seen again some really difficult stuff, kind of Black Lives Matter coming back to the forefront. We've seen the George Floyd and George Floyd. We saw Donald Trump elected as President of America with experienced Brexit. We've seen things like same-sex marriage made legal in 2010, how's that taken so long? We've seen the launch of the iPad. We saw Nelson Mandela died, and race diversity marriages were created. And not forgetting the impact of COVID, which I think is still all recovering from. It's so nice to be here today in a room with people who are happy to do this episode. Legislation again has been continued kind of investment consideration from the NHS. Its staff report published and kind of identified kind of what's the targets that can put at the cost of patient care. NHS included again 5-year forward plan, kind of initiatives coming from this, things like community liaison. So if you presented to A&E with a mental health crisis, you would be seen. Community mental health teams, they're undergoing a transformation programme. And the NHS Health Implementation Plan, and kind of what's at the forefront, which I think is really important. It's kind of the wellbeing of staff this time, in this programme, in this plan, and kind of how staff around can be maintained.
So this was the time I made the decision to go into leadership. I'm not sure if it was the right move, but I did it, and I became a team leader in early intervention. Over a period of time, managing a couple of teams, seeing lots of changes, lots of developments, from separating teams, bringing teams together, employing more OTs, thinking about role of care coordinator within them teams. And again, in the forefront of all of that, still I'm an occupational therapist, and what as an occupational therapist can I bring to the role of team leader and leadership? And within the meetings, and sometimes I dread sitting in, and I could feel myself absolutely panicking, but realising that I need to be here because OT needs to be at the forefront of all aspects of mental health. So team leaded for a number of years, and then made the decision that I didn't want to do leadership anymore. I wanted to go back a bit more to my clinical roots, think a little bit differently. And I was really lucky within early intervention for the opportunity to arise for me to actually be employed again as a clinical specialist, occupational therapist, which brought lots of bows, lots of new things for me to learn again. When someone said, "Can you do a no-host?" my heart just dropped. I thought, I haven't done one for years, and how do I do it? What does that mean? But actually, it's like riding a horse, isn't it? You jump straight back on, and it just all makes sense. It all makes sense. So I now lead in substance misuse within early intervention, a little bit of leadership, so I'm managing and developing that role within the service. So lots of interface, lots of engagement with external services, lots of promoting what we do within early intervention, and also looking at what the role of OT can be within that service and what skills we can bring as designated occupational therapists rather than care coordinator, and having a little bit of time to perhaps do the bits on the side. So it's literally first 6 months in, brand new and developing. So hopefully next year I'll be telling you a bit more about what the role of OT is within early intervention.
Thank you. So from 2010 to now, I've also been in the intervention team of psychosis. health position of care coordinator to start with. I think the position of care coordinator again kind of is really complementary to OT, kind of all the aspects that come within care coordination are really, really important. They lend themselves very nicely to the role of occupational therapy. 2016, a little bit burnt out, needed a challenge, needed something different. And was in a team meeting, heard something being spoken about, didn't really know what it was, signed up for it, and then I was going away from work at a time. Had young children at the time, and just knew my family could be able to cope with looking after my children. And actually, it was such a turning point for me. It led me into the path of where I am now. And I really, really like this idea of psychosis when it comes into a family, how it seems kind of relational context, relational crisis. It's not just seen as a problem in that person presenting with experiences of psychosis. So I got to a 4-year training journey, and that was turned out to 2-year MSc course. And I would say 2 years down the line, I'm just recovering from that master's course. But it still gives me great pleasure. I do every single day. And I just think kind of the core skills of occupational therapy are absolutely fundamental. Kind of in my training and my practice as a systemic psychotherapist. And systemic family psychotherapy kind of speak about self-reflexivity an awful lot. I'm just going to check to make sure I get my definition right. And this is kind of how we act into relationships, a helpful way based on what we know about ourselves. So self-reflexive is about what might be occurring for me in that room. Therapy to use yourself from the OT training was so important for this, to be able to develop this. And I still remember very, very fondly one of my peers who was doing my therapy training spoke about how you never can disclose it like that to somebody that you worked with yourself. And I just thought as OTs, it's very considered what we share about ourselves, how important that is for engagement. Occupational therapy diagnosis will seem way more than that. And again, I found that we're really interested in how they're making meaningfulness where there is. I never, ever, ever would say this, but kind of the reflective nature of training, the reflective logs that I'm being very creative with on occasions, really, really kind of made a good step to me to kind of go on to do this masters. It was about constant reflection on myself. I had that confidence, I had that ability from my OT training. The dissertation, I would say never again, is a real never, ever, ever again. But again, you know, from my OT training, my interviews were something lasted 15 minutes. Whereas kind of when you were from my masters, they had to be a little bit longer. And I think that's the beauty of OT training. There's something about we actually, I don't know if it's changed a lot, but when I did my training, it was you did research and you interview people, kind of where sometimes it's literature reviews and aspects like that. Personal occupation, always an area of interest of mine when I'm meeting and working with families. You know, what can they be doing as a couple? What can they be doing as a family to kind of build on, improve their relationships? Collaborative approach, again within family therapy, kind of this notion of power. How do we share power when we're working alongside individuals? I think again the real importance of the team and the training and kind of practicing this OT for the last 20 years is about the creativity. I'm more than happy to kind of go and sit with the family, just have a flip chart, some ends, and see what comes out in the session. You know, sculpting exercises, using stones to kind of, you know, how people are in the family, distance and closeness between them. Any way that I can be creative with the family just sits really, really comfortably with me. And that comes through what I actually training families and nurses. So kind of these are our final comments, kind of, you know, and it's really evident as well from kind of the presentation that occurred before us. You know, there's more than a variety of opportunities working in mental health. Just because you don't have experience in mental health doesn't mean the skills aren't transferable. Don't ever be careful about querying mental health because you haven't got that experience. Your values, your beliefs will always be yours. I think the beauty of mental health as well as kind of, you know, those additional roles, there's still kind of, you know, doing specific OT stuff, but also it's really creative, anything that you want. And I think we've been really, really lucky in being able to do that and how we work with OTs. I think it's really exciting to see how it's evolved, how it's moved on from kind of being qualified. I think your OT training, that studying, you should have a really solid theoretical basis if you want to go on and do any other training. The NHS policy is constantly evolving, seeking to improve access and outcomes for individuals who experience mental health. I think that's really, really important. Policies constantly look at how can we make this better for individuals who experience mental health difficulties and their families. I think we working in the school for 20 years, we're really proud still to be occupational therapists, and I always still hold those values. When I introduce myself, I always tell anyone, family therapists, occupational therapists, it's really, really important to know that identity.
That's our contact details. Was there any questions or any thoughts that anyone wanted to add? We've got a little bit of time. Anyone wants to add anything to it? So I need to do that.
Just speak up.
Went from a care coordinator role to going back into OT or OT. How was your re-registration journey?
No, so I'm still, as a care coordinators are employed, and part of the, what you have to have is either you're OT qualified or you're nurse qualified, so it doesn't affect your registration in any way, shape or form. So it's almost you're employed as an OT with a different title, basically. I think that's,
Cool.
I think that's why I was quite excited about this new role, because I'm probably not doing anything a great deal different in some ways, but I'm actually can now say my title is Occupational Therapist. That's I'm employed as an Occupational Therapist, and that's recognised. So no, it doesn't affect your registration. You don't have to do anything additional. Just look for care coordinator role within a mental health team, and it's more OTs and nurses now, to be fair. There used to be social workers as well, but I think there's a few more colleges. We've been able to demonstrate evidence actually that we fit really nicely within the environment. And we've touched on a lot of teams that we've both worked in. We have been working with teams with giving opportunities, but there is so much more. As I say, it's a liaison, there's MINs, there's just so much. Substance misuse services, I mean, if we can get OTs within substance misuse services, I think our skills just fit so well. I think it's about shouting to the employer and saying this is what you can do.
Any more questions from anybody? I mean, it's fascinating listening to you, because I completely agree. The breadth of our OT skills, we don't often stop and reflect on how much we have in our toolkits. And equally, you say people can move into mental health, you can move into social care as well. Well, I started in mental health and I ended up in social care. So I think if you're bold enough and brave enough, and you recognise your skills and what you've got and what value you have and what you can bring to a post. As an OT, you can work anywhere under any title, doing anything. It's that OT fundamental core skills. It's that initial training you have that you then grow and develop and build on, and you pick up all sorts of other things as you go along. But the world's your oyster as an OT. You train in mental health, and you train in physical, with LD and with children, with adults. You train with everybody, so you've got this fantastic skill kit. It's amazing what you've got. So
and with a team as well. So sometimes when somebody new joins the team and they've got that different experience, what that brings to the team is immense. Because like I said, so I've worked in early intervention for 16 years. I know I've done different things, but I've been in my own bubble. And actually, when someone new comes to the team, that perhaps has come from a physical health setting or a learning disability setting or social care, actually what they bring to that team really helps the team develop, and it really makes it think about things in a different way to perhaps the ones of us that have been stuck in the chair for perhaps too long and not brought anything else in. So it just helps both ways, I think.
It's just important to recognise your skills, and I think we're often not confident enough. We've all got them, and they're all there in our little toolkits, but it's being confident enough to know what you can dip in and pull out and what you can offer, and be very clear about your skill set. and then that will guide you through your career pathways. But if you have an open mind like that, the world's your oyster, and you can go anywhere as an OT. You'll be amazed. And if you get involved with the Royal College of Occupational Therapists, I'm going to give it another plug. Everyone who was here earlier on. I mean, the opportunities come if you get more involved with all sorts of things. They sent me out to Taiwan 4 or 5 years ago now to talk about reablement services in this country. So that's only because I was working with ARCOP, talking about our evidence-based reablement program that we had in social care. And then things grow from there. And then you get all these wonderful opportunities to do all sorts of things around the world. So don't lose sight of that and get involved. And earlier on, we had a presentation from the allied health professions here. So the allied health profession faculty is huge in health terms. It's not for social care, we're just joining the party. But there are shed loads of opportunities for OTs under the AHP umbrella here in Kent, South East England. So keep your eyes peeled and be brave about stepping into new roles. So, anyway, I'll shut up. Thank you very much.